Welcome everyone. Today we are going to discuss various clinical scenarios on urological infections. Thank you for the trainee who has agreed to record the proceedings so that it will be a good revision source. The first scenario, you have a 32-year-old female presenting to clinic with history of recurrent urinary infection. She feels burning sensation and also at times kind of a low grade fever or malaise for the past few months. How are you going to evaluate?
I'll see her in the female. Usually, we'll have a infection clinic, and then I'll see her in the clinic with further history of onset and duration of the problem. Has she had any previous treatment for recurrent urinary tract infection? And during the treatment, has she grown any organisms that she knew? I would further get more history about her lower urinary tract symptoms, concentrating on any previous history of stones in the renal system, any urological problems, and any operations that she had in the past for any urological abnormality or for the stones. I would get history on any red flag symptoms, otherwise, in terms of visible hematuria, get history on medical history if she is diabetic or if she takes any medications like steroids. I would want to get further history on family history and history of diet, drinking habits, and smoking and alcohol history. With this history, I would carry on further examination with the chaperone present, perform a general physical examination, abdominal examination to check any palpable bladder, external genitalia examination to check for urethral meatal, any urethral meatal abnormality, pelvic organ prolapse, and to check for lower limb neurology as well. During the external genitalia examination, I would want to do a SIM speculum if there is any pelvic organ prolapse to ascertain the problem as well at the same time. After this, I would want to get further information about further examination, further tests, which would be in terms of urine analysis to check for urine dipstick and for cultures as appropriate. I'll organize a baseline blood test, which would be FPC Usenis. And in my practice, I would organize an ultrasound scan to check for upper urinary tract, which is KUB, and also get a post-word residual at the same time. And depending on the symptoms, I would check for a flexible cystoscopy. I'm aware that EAU recommends that under 40 female with no preceding risk factors should not have flexible cystoscopy, but I will have low threshold to get a flexible cystoscopy in order to rule out any abnormality like cancer. With all these information, I'll also get find out her previous urine culture results as well.
Okay, that's good. That's a good opening gambit. Just few things to add, like for example, it's not necessary for every stable, every scenarios you need to mention. Like for example, erectile dysfunction means I will see in dedicated andrology clinic. Stones means I will see in dedicated benign or stone clinic. Not really necessary because of that habit. Now you are little bit struggling to say which clinic to say. A dedicated female clinic sometimes we don't have. You can say I will review the patient in our benign outpatient clinics, so that may
Yeah.
be a broad one, not necessary to say a female urology clinic, which may not be there in many places. Your history is quite in detail. Maybe you can spend a little bit more time on caffeinated drinks, because we
Yeah.
know some advices anyway which you are going to give on a later discussion. So caffeinated drinks and smoking, those things you can quantify it also, not just yes or no, how much coffee and tea, whether it's decaf or not, and also if it is smoking means how much and how long, pack years.
Yeah.
You can discuss a little bit on the menstrual history, which is very important. You haven't touched it. You can discuss about the number of children and the way by which the children were born, because
Yeah.
when you are discussing the urethral prolapse or vaginal prolapse and those things, that has direct impact due to the previous multiple vaginal deliveries or cesarean delivery, which one has happened. During the examination, again, you being a male urologist chaperone, you can bring in. And ultrasound, I will be slightly careful because there is no big evidence to say there is a need for ultrasound for simple, uncomplicated lower urinary tract infection. And also, similarly, flexible cystoscopy, not many examiners will be happy with that. And it's better to stick to the EU guidelines. If you are very confident in saying the flexi or that's your practice in most of the places where you worked, the easiest way is you can look into the urine dipstick. There is a very good possibility patient will be having at least 1 plus blood. So then you can label that patient as cystitis with non-visible hematuria. Then the
Yeah.
quantification of flexible cystoscopy is very high. So when you
Yeah.
say something, try to quantify yourself, and so the examiner will understand, okay, it's a non-visible hematuria. Either way, it's better to have a look into the bladder.
Sure.
So I agree the way by which you are taking. If there is a deviation from the guidelines, as you said, you should mention the guidelines and say why you are deviating. But
Yeah.
you can quantify much better by using the urine dipstick, which may show some non-visible
Non.
hematuria.
Yeah.
Okay, so this lady is otherwise quite healthy. She is a smoker. She has two children born by normal vaginal delivery. Examination wise, she is obese with a BMI of 35. Other than that, the examination findings were nil contributory. Urine dipstick did showed 1 plus leukocyte and 2 plus nitrates. Otherwise, no other positive findings in the dipstick. Ultrasound arranged by yourself showed bilateral normal kidneys. Flexible cystoscopy showed normal bladder mucosa. How are you going to proceed?
I would first of all, her urine shows abnormal results of leukocyte and nitrate. I would go and send that for MSC or cultures. And this, as it suggests, infection, and she is having symptoms. So I would treat her with antibiotics, for empirical antibiotics for that episode. And I'll also, check if she has had any previous MSU culture results, and I would taper my antibiotics accordingly as well. In terms of further treatment, I would guide her for behavioral treatment, or behavioral measures, which would be drinking at least 1.5 liters of water in the bar, emptying bladder regularly, and doing double voiding as required. I would mention about wiping after the toilet from front to back, and educate her on further eating habits in terms of being healthy. Reducing BMI can help in terms of her recovery in terms of healthy living. Since she's a smoker, which can make her have problems in the future, I will counsel her regarding smoking habits to reduce the smoking or to curtail it, and then I'd offer her help as well in terms of referring her to a smoking cessation unit. Further on, I would want to discuss further in terms of non-antibiotic treatment and antibiotic treatment. But I would see her back in my clinic in about 3 months' time with behavioral changes and the initial course of antibiotics for this episode. In my practice, I would generally start them on nitrofurantoin or trimethoprim, depending on their allergic status and pre-medical status, if there is no MSU results available.
Okay, how does the nitrofurantoin act?
Nitrofurantoin acts on DNA synthesis level, which uncouples the DNA and works splitting the DNA.
So what is the dose you are going to give?
And for a nitrofurantoin would be 50 milligrams QDS or 100 milligrams BD.
Okay, to be modified based upon the patient's EGFR. For our patient, EGFR is normal. Okay, And when you're giving these lifestyle changes, you can also include the Bowes information leaflet on female cystitis UTI. I think there is a leaflet which tells about few things to cover. And when are you going to review her? Her urine culture sent reported as E. coli 10 to the power of 5 sensitive to all the antibiotics 5 days after your clinic appointment.
Yeah, I would ideally want to call her, make a call, and see whether the symptoms are have relieved, and I would want to let her know about her urine sensitivity results. If the symptoms have subsided, then I would ask her to stop antibiotics after 5 days, and arrange a clinic for her in 3 to 6 months' time for further review on her symptoms.
What is the role for prophylactic antibiotics?
Prophylactic antibiotics, we can prescribe prophylactic antibiotics in terms of low dose, long term prophylactic antibiotics or self start antibiotics. In her case, we can also check whether there is any role for postcoital, postcoital antibiotics as well.
What is the mechanism behind the postcoital antibiotics?
Postcoital antibiotics works on after a sexual intercourse if there is any trauma in the periurethral region or any history of postcoital infection that would help with further prescription of antibiotics and reducing the infection rate.
Okay, it's not necessarily trauma, it is just exposure to some infective source which can happen, and some women were very particular in reporting to have cystitis episodes after the sexual intercourse, and then gradually it stops and weans off. So those particular women will benefit from postcoital antibiotic. Nitrofurantoin 50 milligram or trimethoprim 100 milligram is enough, should be taken as soon as the sexual intercourse is complete. That's what usually happens. But the best thing is that tablets should be taken before the intercourse, which is precoital. So you should bring precoital. Precoital is the best choice, but it's not possible in the day-to-day life, and then only the postcoital comes into place.
Okay.
Okay. So what is your long-term plan for her?
Long-term plan would be to review her in the clinic for her symptoms. If the symptoms are settled, I would counsel her in terms of continuing her behavioral management. And if she is getting further infections, I would also counsel her regarding non-antibiotic treatment, which in the recent ALTA trial, using methionine hippurate also worked as a non-inferior to prophylactic antibiotics, as in continuous prophylactic antibiotics. So I would counsel her regarding that. And there are other options as well which we can use, which are not antibiotic oriented, like D-mannose. Intravesical Gaxel replacement therapy, and see what and also this depends on what she wants to do in the future. So it would be a shared making decision.
What is the dose for methionine hippurate?
I think it is 1 gram, but I'm not sure. Can't recall the dose.
Yeah, it's 1 gram. I think it should be taken like 4 times a day, so it's quite a large dose, and also it has to be given at least for 3 months to 4 months to see how it's improving. So it's not like a small prophylactic dose; it's a very huge dose, and the main problem is it is shown only as non-inferior to antibiotic prophylaxis. So it may end up very good in the principles of antibiotic stewardship to produce unnecessary antibiotic resistance, etc. But we need to wait and watch for further acceptance. What about the gag layer protectors you mentioned? What you will prescribe?
Yeah, this is an intravesical gag layer replacement in terms of hyaluronic acid and chondroitin sulfate. And these are given according to the local protocol. From my practice, we give once a week for 6 weeks and once monthly for next 12 months, 6 to 12 months to see how the symptoms work for them.
So how will you set up the dosage?
I think they come in pre-filled sac, and after catheterization we instill. I'm not sure whether we cap the catheter and then allow that to stay for a few hours.
Yeah, it has to stay for a few hours, at least 2 hours, just like mitomycin and other things. The only thing which is interesting is there are some products like Iuluril which is available by patients self-application. So patients can get the prescription and they can self-apply in their home, and they can walk, they can lie down on different sides to make the medicines to touch all the surfaces of the bladder, and they can void after 2 hours. Not necessary for all the patients to come and clog up the urology nursing clinic. So that's one of the main things. Self application is
Yeah.
available, and not all the drugs are available, but Iuluril and few other things self application is available. Okay,
Yeah.
so in summary, this is a definite scenario to discuss. The main things, there are a lot of weightage to be given for the history to make sure you are ticking the boxes like childbirth history, and you can even bring in some family history, because there is a good link between the persistence of UTI in mom and grandmom and continuing in the family, and marital history, coital history, menstrual history, and examination wise BMI. And I'm happy with your lifestyle changes and giving importance to BMI and not exposing to smoking, etc. Otherwise, it's quite straightforward, and bring lot of weightage to antibiotic stewardship, antibiotic prophylaxis, and the newer non-antibiotic medications like, as you mentioned, D-mannose, methyamine purate, and self-application of gag layer protectors. That will complete the full picture. Okay, good. Can we go for the next scenario?
Yes, please.
Okay. You have a patient, 71-year-old, attending for prostate biopsy. How you will explain the risks of infection with this patient?
Um, um, uh, I understand this gentleman has been coming to prostate biopsy with for PSA increase raise, and then I would check with him whether he has had any previous biopsies as well. In terms of prostate biopsy, I'll counsel him regarding the procedure along with the BIOS information leaflet. I would inform him about the risk of the procedure. I would want to know whether he is getting this biopsy under trust guided, as in trust biopsy, or template, transperineal biopsy. If he is getting this procedure through trust biopsy, I would explain him that there is a risk of bleeding, infection, sepsis, and urine retention. Bleeding can happen in the waterwork for few days, which will stop on its own. Again, the same with bleeding from the back passage and in the semen. In terms of infection, the risk rate is less than 10% in trust biopsy, and sepsis is less than 1%. With regards to urine retention, again, it may, I know it's around 5 to 10%, and this is mostly secondary to clots. I would tell him about further benefits and of the procedure, and further need for repeat procedure as well in the future. If it comes back as negative, and as negative for malignancy, he will be further for surveillance in terms of PSA and MRI scans. If he is undergoing a transperineal biopsy, the risk of infection are lower than trust biopsy. The infection is UTI would be around 1%, and the sepsis is around 0.1%, and urinary retention is around 1 to 2% as well. So I would counsel him regarding these things, and perform the procedure as appropriate.
Okay. Why it is important to differentiate between transrectal ultrasound guided biopsy and transperineal biopsy?
As we know, there is a lot of research and trials has happened before in terms of trust and transperineal. There are two reasons why we would want to select either one of them. One is about the histology, the amount of tissue that we get, and then the clinical significant cancer that we can achieve through different biopsy route. And also, secondly, it's more important now with the infection post prostate biopsy infection. And also, secondly, more importantly, it is about antibiotic stewardship as well. The latest EAU guidelines suggest that if wherever possible, the units have to change to transperineal biopsy, and this can be done under local anesthetic, as the complication risks are lesser when compared to trust biopsies.
Okay, so what antibiotics you use as prophylaxis?
In our practice, I use ciprofloxacin and gentamicin before the procedure. If it's trust biopsy, we also do a metronidazole as well parectally just before the procedure. I'm aware that the new guidelines from EAU mentions a few things in terms of targeted antibiotics, which we target the microorganisms based on the rectal culture or stool culture. Or we could do an augmented prophylaxis, which would be enhancing the prophylaxis with at least two broad spectrum antibiotics. If these are not possible, we can do an alternate prophylaxis, which would be using alternate antibiotics which are not used in daily practice for UTI, which would be, for example, fosfomycin. So these are the theory behind the infections.
Okay, is there any precautions in using ciprofloxacin?
Ciprofloxacin, as we know, this is now entering into quite a lot of antibiotic resistance, and we have to make sure that the patient has not got any previous previous resistance for the organism, and have to make sure this is not cultured as ESBL in the feet in the past, because ciprofloxacin wouldn't work, and this should be used according to the trust guidelines as well, which is based on the local or regional cultures.
The other very important thing with ciprofloxacin is this tendon damage, tendon fractures, which is a recent one. You can also bring them. Even though it's more specific for the pediatric population, ciprofloxacin can cause tendon weaknesses, which can result in tendon fracture. And C. diff infections resulting in Clostridium difficile and colitis symptoms also can be highlighted with ciprofloxacin. Slowly, there is a good possibility ciprofloxacin may be quite out of practice. You said you are giving gentamicin. What is the dose?
This is actually based on the renal function, and there are gentamicin calculators in trust which we use. But in general, we use we can use 3 to 5 milligram per kilo body weight.
Okay. Is there any other steps you can take to prevent the infection? Say, for example, you have no availability of transperineal biopsy. You have to do transrectal biopsy. Any other advantages or any steps you have to prevent urinary infections?
EAU also mentions about preparing the patient with povidone iodine just before the procedure. And further things is to ensure that a patient understands about the urine. If he has got any LUTs and things like that, we should be treating that before the start of the treatment.
Yeah, apart from this, if you see EAU guidelines, they mention like limiting the number of cores can reduce the chances of infection, which obviously we will try to do. But in case if there is any clear-cut targets available in the MRI, we can do some targeted biopsies and reduce the systemic lateral biopsies. and prostate block by starting, which we anyway do, is also seems to be a good technique to reduce the urinary infection, even though we don't know what is the mechanism behind that. Okay, so your patient had uneventful transrectal guided biopsy. You took 4 course of targeted biopsies on the right side, and then maybe another 4 course each on left and right side peripheral zone. Patient presented after 24 hours to A&E with high swinging temperature. What will you do? He got gentamicin, metronidazole, and ciprofloxacin started by you.
I'm concerned that this patient now has got prostate biopsy sepsis, and I would go and see him myself as a ASAP. I would, on arrival, I would check the assess patient with A to E protocol, making sure that patient is stable, and I would start him on sepsis 6 protocol pathway. According to sepsis 6, I would give him IV fluids, intravenous broad spectrum antibiotics, and put a catheter in if need be, in terms of to get urine output measurement. I would further get blood investigations for FBC, use any CRP, and send that for blood cultures as well, and also get lactate at the same time. I'd also get urine for urine culture. So after starting these medications, making sure the patient is stable, I would also liaise with my outreach team if the new scoring of the patient is more than 7, because he might likely need HDU care as well if the sepsis is going into septic shock.
Okay. How will you assess a patient who may be presenting with septic shock?
I would assess him with Q-SOFA score, which is a new score, which is sequential scoring for organ failure. With certain parameters, more importantly, which are blood pressure, respiratory rate, and mental status examination with GCS. If these scores are more than 2, then he is defined as being in sepsis. So I would assess him regarding in a Q-SOFA and take it from there.
Okay. Is there any protocol you have in approaching a septic patient?
I would want to approach a patient with the A to E manner, which is airway, breathing, circulation, checking any disability and exposing to see whether there is any other abnormality. I would, first of all, after all the A to E examination, making things stable, I would check on his history and do a general physical examination with the organ-specific examination as well.
Okay, what is Sepsis 6 protocol?
Sepsis 6 protocol, it's a bundle which is instituted to treat the sepsis patient, and it is very reliable and useful during the first hour of any sepsis. That would be involving IV fluids, IV antibiotics, and oxygen. Taking out blood for blood culture, general bloods, and lactate, and urine for urine culture.
Okay, you can follow a kind of uniformity like sepsis 6. You can start from head to toe. First is giving the oxygen in the face, and then placing a venflon on your taking blood samples for, say, as you said, lactate and blood culture, and you are giving IV fluids and antibiotics. So you're giving and taking in that order, and you can finish off by saying that you will place a catheter to monitor the urine output. What is your antibiotic policy for this gentleman now? He is septic and you are able to stabilize him with IV fluids. What is your antibiotic policy?
Yeah, this gentleman is in sepsis. As we know, the antibiotic policy would be based on the local trust guidelines. However, in my practice, if there are, according to the guidelines, I would give co-amoxiclav with gentamicin to cover broad spectrum gram-positive and gram-negative organisms. Yeah, I would start with this.
Okay. And what do you think this patient's urine culture or blood culture will grow?
I think he most likely he will grow E. coli in about 60 to 70% of the patients with sepsis from sourcing from urinary infection. They would be E. coli.
Okay. The examination showed in rectal examination quite a bogginess in the prostate. So what's happening?
I'm concerned that this patient might have got prostatic infection in terms of abscess formation or hematoma, which has now turned into an abscess.
So how will you approach it?
I would give him analgesia because these patients will have severe pain, and give him broad spectrum antibiotics. To get further assessment, I would organize for MRI scan. As I understand, this is an acute abscess, which is certainly a painful situation to get a truss scan and confirm my diagnosis with an MRI scan. Once I am sure that there is some collection, I would approach my interventional radiology team to check whether we can drain it percutaneous route or through transrectal route under anesthesia as appropriate.
Okay, the MRI did show presence of 28 millimeter collection on the right side of the prostate. And what is the other methods of draining the prostatic abscess? Why you want to depend only on the intervention radiologist? Is it not possible by yourself?
Yes, there are other methods like the transurethral route for which we have to give general anesthesia to the patient, and because the patient is already septic, and I'm concerned that this can be an anesthetic problem as well. It can be problem in terms of patient going to ITU or HDU care in the post-operative period. So my first port of contact would be percutaneous route and that would be done by interventional radiologists.
Okay, I mean you can still keep transrectal route as one of the option because the biopsy was done transrectally. So if at all if there is any abscess or collection, it will be more amenable transrectally than transurethral. I agree with your view that in the presence of the sepsis, transrectal doing under local anesthesia will be very uncomfortable and could be intolerable for the patient. So you can say that I will keep the anesthetic in place and try to do a transrectal approach both for aspirating and try to decompress the abscess. But the anesthetist will be there to give any type of IV sedation or even LMA mask short GA also. What you will do with the specimen collected by the prostatic aspiration?
So once I get the specimen, I would send it for the microbiology cultures and gram staining as well at the same time.
Okay, and the anaerobic growth has no growth at all. The aerobic has grown further E. coli, but seems to be sensitive to all the antibiotics except ciprofloxacin. So, is there any change in your plan now?
Yeah, I'm concerned that this patient might have grown ESBL, and I would, personally give a call to a microbiologist to check what kind of organisms that he has grown and what kind of antibiotic sensitivity he has got. And after discussing with my microbiologist, I would start him on appropriate antibiotics. If microbiologist is not available, I would start him on carbapenems, which would be the ESBL are sensitive for that. In my practice, I would give meropenem.
Okay, good. That completes the complete scenario. After changing the antibiotics, the patient gradually improve, and then further follow up based upon the biopsy is a different table, the prostate cancer table. So, you have any questions to ask before we complete today?
No, Sadi. I think I'm okay. Is this sort of way is okay, or do we have to brush up our presentation in terms of anything to add for the second scenario?
Yeah, actually, we have finished almost like three scenarios. The first one is the female cystitis UTI scenario. The second one is patient coming for prostate biopsy, ways to prevent infection. That itself is a scenario. And the third scenario is the obvious septic scenario post prostate biopsy. The third scenario can be anything. It could be just renal abscess, spontaneous or diabetic, or it could be surgical abscess, like a patient who had a ureteroscopy and then ending up having some pyonephrosis, and the approach of the sepsis 6, everything will be the same. Or it could
Yeah.
be like the prostate biopsy, like how we do it. Can be even a post TURP. Any post surgical biopsy can present in the same way. I have no major feedback to give. Maybe you can get yourself a little bit more stronger in the non-antibiotic treatment for female UTI. Get more dosage and regimens regarding the
Yeah.
methylminipurate, D-mannose, because they're all quite new, and people will be very happy if you can mention a couple of lines on the Altar study,
Yeah.
which journal it published, and then you correctly mentioned it's a non-inferiority study. That's a good one, and maybe you can remember some numbers, but I won't advise really going too much into the article quoting, especially for the infection table.
Yeah.
And sepsis 6 should be much more straightforward, and you can bring sepsis 6 and the protocols quite spontaneously. Don't allow the examiner to ask what is sepsis 6. Otherwise, your approach is fine. Wait for the antibiotics. Start with broad spectrum antibiotics, and then monitor the vitals with QSOFA, and also make sure that patients' vitals are monitored and antibiotics appropriately changed based upon the culture. Learn little bit more about the the ESBL, what is the prevalence, and what may be the steps we can take to prevent ESBL in the community perspective. So
Yeah.
that will complete the whole reading in these scenarios.
Sure. Sure. Thank you. Yeah.
Good. Well done. We'll complete for today, and we'll discuss in another table on a different day.
Sure.